Welcome to Roadmap to Residency's Medical Licensing Exam Step 2 Prep Series. Today we're tackling pneumonia, one of the highest yield topics you'll see on your exam. This video focuses on test-taking strategies and question walkthroughs, not just memorizing facts. For the core material, review your first aid, UWorld explanations, and your preferred infectious disease resources. Don't forget to like, subscribe, and check out our expert tutors and residency advisors at roadmaptoresidency.com. Let's get started. By the end of this video, you'll be able to rapidly calculate the CURB-65 score, select the right antibiotics based on clinical setting, and recognize those classic question stems that signal specific diagnoses. The exam loves to test your ability to integrate severity scores with antibiotic selection, so pay close attention to how these concepts connect. Before diving into questions, let's establish the critical framework. The two questions you must ask yourself when reading any pneumonia stem are, where was it acquired? And what is the severity? Community-acquired means outside the hospital or within 48 hours of admission. Hospital-acquired develops after 48 hours. Ventilator-associated develops after 48 hours on the vent. The CURB-65 score determines disposition, confusion, urea greater than 7, respiratory rate 30 or higher, low blood pressure, and age 65 or older. Each point matters for deciding outpatient versus inpatient management. Here are your high-yield buzzword associations. For community-acquired pneumonia, when you see lobar consolidation plus rusty sputum plus acute fever, think Streptococcus pneumonia, the most common cause. For hospital or ventilator-associated pneumonia, the 48-hour mark is key. After this threshold, you're dealing with gram-negatives like Pseudomonas and Staph aureus, including resistant strains. For aspiration pneumonia, look for stroke patients with dysphagia, foul-smelling sputum, and involvement of the right lower lobe. This combination screams anaerobic bacteria. Let's walk through our first case. Read it carefully and try to identify the CURB-65 components before I reveal the answer. This patient has productive cough with rusty sputum, high fever, and right lower lobe consolidation. The question asks about disposition. Here's how to approach this systematically. First, calculate the CURB-65 score. Confusion is present, that's 1 point. Urea of 28 is above 7, that's another point. Respiratory rate of 28 is below 30, so 0 points for that. Blood pressure is borderline but not meeting criteria for systolic below 90 or diastolic below 60. Age 68 gives us 1 point. Total score is 3. A score of 3 or higher indicates high mortality risk. This patient absolutely needs admission and likely intensive care unit level care. The test-taking tip here is to immediately scan for these 5 components whenever you see a pneumonia case with vital signs and mental status. Now let's look at a different scenario. This healthy patient with no comorbidities has a low CURB-65 score of 0. The key question is asking about outpatient antibiotic selection. Read through the choices carefully before I explain. This is where understanding the guidelines pays off. For a healthy outpatient with no comorbidities, monotherapy is sufficient. Azithromycin alone covers both typical organisms like strep pneumonia and atypical organisms like mycoplasma. Why are the other choices wrong? Amoxicillin alone misses atypicals. Levofloxacin is reserved for patients with comorbidities or recent antibiotic use to preserve this important drug class. The combination of ceftriaxone plus azithromycin is inpatient therapy, not outpatient. Here's a summary slide on antibiotic selection. This is essential to memorize. For outpatients without comorbidities, use monotherapy with a macrolide like azithromycin or doxycycline. Once you add comorbidities or move to inpatient settings, you step up to either a respiratory fluoroquinolone alone or a combination of beta-lactam plus macrolide. The exam frequently tests these distinctions, so know them cold. Case 3 changes the setting entirely. Note the timing, post-operative day 5, and the fact that the patient has been mechanically ventilated since surgery, new fever, purulent secretions, and a new infiltrate. What organism is most likely? The key to this question is recognizing that more than 48 hours on mechanical ventilation equals ventilator-associated pneumonia by definition. This completely changes your differential. Community-acquired organisms like strep pneumonia and mycoplasma are wrong answers here. The correct answer is Pseudomonas aeruginosa. a common cause of ventilator-associated pneumonia, especially with prolonged hospitalization. Legionella, while sometimes hospital-associated, comes from contaminated water sources, not ventilators. When you see the ventilator plus 48 hours, immediately think resistant gram-negatives and Staph aureus. Case 4 introduces aspiration pneumonia. Notice the nursing home setting, history of stroke with dysphagia, and the patient coughing while eating. These are classic risk factors. The foul-smelling sputum and right lower lobe location seal the diagnosis. Let's analyze the clues. Stroke with dysphagia creates aspiration risk. Nursing home residents and coughing while eating confirm it. Foul-smelling sputum indicates anaerobic bacteria. The right lower lobe posterior segment is where aspirated contents go in a supine or semi-recumbent patient. Now for antibiotics, we need anaerobic coverage. Ampicillin sulbactam is correct because it covers oral anaerobes and streptococci. Azithromycin does not cover anaerobes. The vancomycin plus piperacillin tazobactam combination is for hospital-acquired pneumonia with resistant staph risk, not aspiration. Trimethoprim sulfamethoxazole has poor anaerobic coverage. Our final case is severe community-acquired pneumonia. This patient is critically ill with septic shock, multilobar infiltrates, and requires intubation. What antibiotic regimen is appropriate? This patient meets major criteria for intensive care unit admission, specifically mechanical ventilation requirement and septic shock. For severe community-acquired pneumonia requiring intensive care, you need broad coverage. The correct answer is ceftriaxone plus azithromycin plus vancomycin. The beta-lactam covers typical organisms, the macrolide covers atypicals, and vancomycin is added for methicillin-resistant Staph aureus risk, which is indicated by his comorbidities and severity. Options A and B don't provide adequate coverage for this severity. Option D is a hospital-acquired pneumonia regimen with piperacillin tazobactam, which is not the first choice for community-acquired pneumonia even when severe. Remember, for more in-depth content review, check out your First Aid, UWorld, and Board Review resources. And don't forget to like, subscribe, and visit roadmap to residency.com for expert tutors and residency advisors. Good luck on your exam.